Hey guys, Dr. Erica Wood, and this is the next part of our lecture. So, as I said for the other one, if you don't want your children to hear anatomical terms or words or see pictures of anatomical aspects of female reproductive system, then turn off the sound or put headphones on or ask your kids to go play. Okay, so on that note, we're going to start our share screen and we'll get started. So we're going to talk about the female reproductive system. So let's get it on. Let's get it started. So so male versus females are a little bit different because females, most of the genitalia is on the inside of the body that we can physically see. Or not physically see, and that's including the ovaries, the duct system, which is the fallopian tubes, also known as uterine tubes, and the vagina. And then the external sex organs are the clitoris and the vulva and labia, or labia majora, labia minora. So when we're looking at a cross section or mid-sagittal section of the female pelvis, what we're going to see is the urinary bladder is most anterior. Next comes the vaginal canal, and then posterior rectum. So here, right over here, is the vaginal opening. Posterior to that would be the anus. Anterior to that would be the urinary bladder. Okay, sorry, I'm getting a lot of emails all of a sudden. And then anterior to this would be the clitoris, and the clitoris is the equivalent of the erectile bodies or the corpus cavernosum in the biological males. Okay, as far as how this uterus hangs around, there's a bunch of ligaments that hold it together. It is in the pelvic cavity, so consider abdominal pelvic. And men and women, biological men and biological female, or it doesn't even matter who, all genders, all sexes have a pelvic floor, and that is made of muscles called the levator ani that help keep pelvic organs where they're supposed to be. Okay, so the ovaries are the gonads, and those that's what house the ovum. So in the male, the testes, sperm is made every day. In the female, in utero, it is predetermined how many ova that female will be able to make in their entire lifetime. And not all of them are released. Some of them are just pushed out to, or not pushed out, we'll get into them, but some of them just not used at all. And the ovary is, they're two almond-shaped little nuggets that hang out at each side of the uterus, and they're held together by ligaments. One of the most important ligaments to know about is the broad ligament, because that supports the entire uterine aspect. Ovaries have their own blood supply, and it's called the ovarian arteries. It's like a branch off the abdominal ovary, and it also has a branch of the uterine arteries as well. This is important to know because something called ovarian torsion, same thing in the males, it can happen as well, but ovarian torsion can occur where the ovaries, even though they're attached to that ligament, they turn on themselves and kind of strangulate themselves. Each of the ovaries has a fibrous cover called the tunica albuginea. Okay. So if we're looking at, or if we just took the internal female reproductive system, we're looking at the posterior view here. So we're looking at the uterus right here, the fallopian tube with its fimbria. Fimbria is it's a Latin word for fingers, and they don't actually fully touch the ovary right here. They actually just hang out and float. And here's a cross section of everything. So vaginal canal is, it's a canal, so there's a lumen. It's lined by stratified squamous epithelium, and it has a muscular wall, and that muscular wall has a lot of elastic to it, elastic tissue, because it needs to accommodate for sexual intercourse and also for birthing a baby. So birthing a baby, this area right here, the cervix, has to open to birth a baby. In a person who's never been pregnant or is not pregnant, this is about the size, the opening is about the size of a pinpoint or even a pencil point. When the baby's ready to be born, it can get up to 10 centimeters. So it needs a lot of stretch. We have the uterine wall, and we'll get into that in a few moments. The uterine wall has 3 different layers to it and is a hollow organ. And then we'll get into the different aspects of the ovary as well. So ovaries, there's a cortex that houses all the different areas where the gametes are formed, and then the inner medulla is where all the blood vessels and nerves form. So ovaries make what's called follicles, and these follicles are tiny sac-like structures that are embedded in the cortex, and they're immature eggs, or eggs are another word for eggs, an oocyte. And each month through FSH, a egg is ripened or basically help to mature until it's ready to be ovulated, which means out with the ovary into the fallopian tube and down the hatch it goes to get either shed as in the menses or to meet up with a sperm and form a baby. The female duct system is composed of the uterine tubes, which is fallopian tubes, as I said. And we don't really need to go so much in depth on that one. So fallopian tubes, they're about 4 inches long. And as I said, they have fimbria. That's the most important. I want you to know about the fimbrias. Don't fully touch or are adhered to the ovaries. They kind of just float in the ether because their idea is they're supposed to be there to catch the eggs as they're released. So this can become important because there's something that can happen where there is a pregnancy that occurs outside of the either fallopian tube or uterus, and that's called ectopic pregnancy. Most commonly, this occurs in the fallopian tube, but it can happen in the abdominal cavity as well because there is that little bit of space where the egg can travel to. Okay, so what is the uterine tube? As I said, it's meant to sweep the ovarian surface to carry the oocyte down the tract. It contains a little bit of a, so the oocyte has a little bit of a ciliary action, and the smooth muscle in the urine and the fallopian tube wall can contract, which allows the egg to move down the hatch. Okay, I already talked about ectopic pregnancy. Typically, these will occur as extreme pain, substantial amount of bleeding can occur, and it's always an air differential for any female that is of fertile age. Okay. As far as what can also happen is called pelvic inflammatory disease. And what that happens is there's a sexually transmitted infection, most commonly chlamydia or gonorrhea, that goes untreated because some of these STIs or sexually transmitted infections actually don't cause any symptoms until it's too late. Most of the time they do, but sometimes they cannot. And this can lead to inflammation and infection of the entire uterine cavity and can cause scar tissue and unfortunately to infertility. So uterus is a muscular organ. It's meant to contract. It's full of smooth muscle. Its normal position is called anteverted, which means that it's inclined forward or towards the anterior aspect of the body. Retroverted, it's also very common, means it's inclined backwards. Just really means a matter of when someone's doing a pelvic exam, they're trying to feel for a uterus and it's retroverted. They probably won't feel the uterus unless it's really enlarged. Uterus has different portions. I'm going to actually use this slide right here to show it. So we have the fundus up here, we have the body. And then we have the isthmus, which goes into the cervix, or also known as the lower uterine segment, and the cervix. And then the cervix itself communicates with the opening, which is called an os. There's an internal, external os. The internal os communicates with the uterus and the cervix. And the external vaginal os, which is the one that we can see when we do a pelvic exam, it connects the vaginal canal to the cervix. The cervix, as far as females normally from ages 30 and below have to get tested for something called HPV, which is a sexually transmitted infection, and that can cause cervical cancer if left unchecked. What that means is that the cervix, and just, I don't know, that was a random side trans there, but the cervix actually has glands in it. So if females notice that they have more mucus secretion throughout their cycle, it's because these cervical glands are secreting mucus, and what that does is it helps block sperm entry, except for during ovulation, or mid-cycle. So honestly, there is only normally about a 5 to 7 day window of when a female can get pregnant. Other than that, there's really no exit route. But here's the catch, okay? Where everyone's like, woohoo, no protected sex or something like that. It's very hard to predict a cycle for a female, especially if there's stressors or colds or viruses or anything, basically. A lot of people like to use the natural family planning where they really check their cervical mucus, check the position of their cervix, all this stuff. And it can be very effective if you're very good at it, but it's very hard to be very good at it, and 9 times out of 10, you will get an unexpected pregnancy because things change. Your body is not always constant with the menstrual cycle. We'll be in a nice world that we could be. And as I said, we do PAPs because we're trying to look for cervical cancer, and this is a change of cells. So in the vagina, we have squamous cells that we're looking for, and in the cervix, we start seeing a little bit of a contrast once we're at the we're at the junction of the internal aspect of the cervix. We go to more of a columnar epithelium. What ends up happening is that HPV infects these squamous cells, and we see changes that occur. And those changes cause bad things like cancer. So we do have a vaccine that can prevent HPV, and it's actually not just for biological or any, regardless of sex. It's not just for girls anymore. It's for men and women. And then after 30, what we can do is we can do a PAP every 5 years instead of every 3 years. And this includes HPV testing, because if you don't have HPV, then you're most likely not going to have a cervical cancer that is from it. And at 65 is when we stop doing PAPs, or after a hysterectomy, there's really nothing to PAP there. Some people beg to differ. And then if you have not been sexually active at all, then there's really no reason to do a PAP. Well, I still would do a PAP, but there's not as much as a clinical urgency to do that. So how does the uterus stay in place? There's something called the mesometrium, and that's supports the broad ligament, which is a ligament. There's basically, in a nutshell, there's a bunch of ligaments that hold the uterus together. There's a round ligament. I just want you to know the uterus is held together by ligaments. Okay. What happens when these ligaments can get overstretched or sometimes torn is called prolapse of the uterus. Uterus can sink into the vaginal opening. The uterus can also push onto the rectum or push onto the bladder. So not a fun time for all. The uterine wall, so the uterus itself is made of 3 layers. We have a perimetrium, which is the outermost layer. It almost looks shiny when you're looking at a dissection. Oh, you know what? I forgot to take my allergy medicine. Ha ha! Okay. I'll do that in a moment. You guys must really think I'm crazy if I'm always like, haha, every single time I lecture. And then we have the myometrium, and this is the bulk of the, hold on one second, I'll put you guys on pause. Oops, I think you guys were recording for all that. Sorry about that. So myometrium is the bulk of the uterus, and it is made of smooth muscle, and the smooth muscle interlaces, so it can contract in a rhythm-like fashion to get that child to exit out. And then the lining of the uterus is called the endometrium. This is simple columnar epithelium. And what happens when an egg that's fertilized normally the egg gets fertilized in the fallopian tube, and it makes its way down in 4 to 5 days and implants itself into the uterine wall. And the uterine wall then, the fertilized egg then burrows, like literally like this, burrows into the endometrium and stays there until it's, for the rest of its development. It's the site of implantation. We can actually sometimes see the site of implantation when we dissect a placenta when the baby is born. So there are different layers of the endometrium, and there's 2 layers that we really need to know about. And it's a huge blood supply. Why? Because we constantly need to, for the female reproductive system, you constantly need to shed, and you constantly have to be, the purpose of the endometrium is to be ready for implantation. So it's 2 layers. And they're called strata. There's a functional layer called the stratum functionalis, and what it does, it changes the response to the ovarian hormones and sheds during menstruation. So that part always goes away. But just like in sperm, in the testes, how we have those daughter A cells that always stay as the stem cells, and daughter B cells that become sperm. kind of the same idea here, but a little bit different. So we have the stratum basalis, or the basal layer, and that forms a new stratum functionalis after menstruation. It's unresponsive to ovarian hormones. Its pure purpose is just to be there to keep it all going over and over again. And then as far as the arteries go, we have uterine arteries that come in to supply the endometrium, and that those lead into the arcuate arteries, which are in the myometrium, and this becomes radial arteries in the endometrium. The radial arteries then become either straight arteries in the stratum basalis or spinal arteries in the stratum functionalis. It's important to know about these spiral arteries, though. These spiral arteries degenerate and regenerate, and they're responsible for the spasms that occur to shed that functional layer when females menstruate. And I apologize if I keep saying we. I still have that common problem. I'm always associating that everyone is me, and that's not cool of me. So sorry about that. And hold on one second. Okay. So this is taking a look at the histology. If we took a slice of about halfway thick of an of a uterine wall. So here's the lumen. This is just the space that hangs out in that hollow organ. We have the epithelium. So we have some columnar cells right here, and you see how there's a functional layer and then the basal layer. And in this basal layer, you see the spiral arteries. Okay, down here is myometrium, and this is all smooth muscle. We have females have no control, biological females have no control about when they can control their cramps. If they could, biological females would be very happy campers and not have PMS. Okay, so the vagina, and yes, vagina, vagina, vagina. I sound like kindergarten cop. Boys have penises, girls have vaginas, and that's not fully true. Anyways, so vagina, it's pretty thin-walled, but it has a lot of stretch, and it's about 3 to 4 inches in length. And it's meant for birth canal, so it's a area. It's an exit route and an entrance route. So exit route for menstrual flow and the baby, entrance route for sexual intercourse, so so we can make new humans. And then the urethra runs parallel and anterior to the vagina, which can be an issue because most commonly females get UTIs, biological or transitional as well, depending on how they reform their gender confirming surgery. So what happens is that during sexual intercourse or any kind of sexual activity, there's a friction that occurs from the vagina to the urethra, and that introduces bacteria that we may not, or females may not want in that area. So, and it's also shorter, so that's a reason why. Shorter route to get to the bladder, more likely to get an infection. And then it's lined by stratified squamous mucosa and has rugae, because anytime you have rugae, it's meant to expand and contract. The vagina has a couple of secretions. Remember in the male discussion that males are mostly make a basic semen, and that's to help neutralize the acidic environment of an adult female. But in adolescence, most of the times these vaginal secretions are more alkaline, and we think about that. So in today's world, most women, and I'm not saying for all, or most people are having babies later in life, okay? Which could be part of the reason why fertility or the ability to get pregnant gets altered a little bit, because back in the day, and I'm talking like back in like BC and 1600s, females were getting pregnant around 16 to 24 as the common age, and it was very easy for them to get pregnant because of this alkaline area. There is a portion there's a little portion of tissue that's called the hymen that basically covers the vagina, and that only ruptures with intercourse, and that is meant to protect the lumen and protect the inner aspect of the vagina. And then there's a part of the vagina, I normally have an anatomy thing of the vagina and uterus in my office, but my boss took it, and she's with a patient, so we don't do that. So typically, so I'll use my hand here. So the cervix will dip down into the uterus, not into the uterus, into the vagina, and there's like almost like a tiny little cup, not a real cup, but it forms almost what appears to be a cup. This is called the fornix, and this is typically where sperm kind of enter or get trapped, and they pool to make it easier to get into the cervix, or a common place for vaginal infections to start occurring. So external genitalia are also known as vulva. So we're going to use medical terms, but I don't want to hear any you can imagine the terms that are used for male and female genitals, but we're going to use anatomic terms here. So we have the mons pubis right above here, and this is where the pubic hair is centered at. This is going from the pubic symphysis to the outward aspect, and this is a fatty pad that is meant to cushion the vaginal air, or the external genitalia. Then, just like in the male reproductive system, there's a prepuce, or a foreskin, is in essence, and the clitoris, which is the glands, which is almost equivalent to like the glands of the penis. We then have an area called the vestibule, which basically houses the urethra and the vagina. We have the labia majora, which is the outer part of the vagina, of the vulva that we see. This is the skin that we normally that you see on, if you're someone who's just in the anatomical position for a female, biological female, or transition female is laying in the anatomical position, you would see. And then if you were to have them be in a frog leg position, you would see the inner aspect. There is another protective layer called the labia minora. It is not skin. It is more of the same epithelium that lines the vagina, but it also serves as double protection, meaning that its idea is to protect the vulva from infections. So that's why everything is closed off, because we don't want the vagina just to be like poof, and there's a bunch of bacteria that can enter. Here we can see that the hymen is ruptured on here because we don't see the tissue, okay? You can tell on a pediatric patient if their hymen is intact or not. We don't go really looking very often unless there's suspicion of abuse, okay? And then in the perineum, so the perineum is the space between the anus and the vagina. Kind of went to everything here that you need to know about. There are glands that are flanked the vaginal opening. I'm going to come back right here. The glands normally hang out right here. And they're kind of like the bulbourethral glands of the penis. So their idea is to make mucus that help with lubrication for intercourse. And then the clitoris, I just already talked about as well. And it's just like this corpus cavernosum of the penis. And with sexual stimulation, it engorges. Talked about the perineum already. We don't need to look at all these things. This is looking at the glands here. So here we have those bulbourethral glands right here. Sometimes we'll have, there'll be cysts that can occur over here, okay? If we're talking about female gross reproductive anatomy, then we have to talk about mammograms, aka the breasts. So everyone has mammary glands, but it depends on the hormones that are present in the body that stimulate their growth and their use. And also prolactin. So men can lactate if there is a tumor in their brain that is secreting prolactin. So men, biological men who are, or even, it doesn't even matter, just men in general, if they're secreting milk, we start thinking, and they're not pregnant, then we start thinking, and obviously biological men aren't pregnant, but we start thinking, is there a tumor? So the mammary glands are modified sweat glands. So if you're looking at the outer image of a breast, we see a nipple in the center, an areola, which is the pigmented area, and it actually has a purpose. The areola during pregnancy darkens, and it stays dark until the infant is born to about 2 to 3 months, because it makes infants, when they're first born, can't really see really well. So that dark versus light contrast allows them to find that nipple easier. And then the breast itself is attached to the pectoralis muscle by suspensory ligaments. So the breast itself are composed of fat and fibrous tissue. The fat component, it depends on genetic makeup, and so does the fibrous component. Just because someone is large-breasted doesn't mean they're going to have more milk production when they're postpartum, and vice versa. Same thing as breast cancer. Just because someone has very large breasts doesn't mean they're more at risk for breast cancer. It really matters about how much fibrous tissue is in there. So the breast tissue itself is made of lobules, and with each lobule, there's an alveoli, and this should sound familiar, like almost like the lung. So when milk is made, which is by prolactin, prolactin is then makes the milk, and then with oxytocin, a letdown occurs. The milk is passed from the lobules into the ducts, and in through the ducts and out of the nipple. Okay. And if the woman is not, or if someone is not nursing, then this glandular tissue is not really well developed at that time. It's always there. And I said breast size is normally due to amount of fat deposits. but in some women, there's a ton of fibrous tissue that can make up for some of that fat deposit. So it's not always true right here. So if we're taking a cross section of the breast, we see the adipose tissue right here. We see all these little lobules, and then leading into ducts. Ducts lead into the areola, which is that outer darker region, into the nipple. We can't talk about breast without talking about breast cancer, which is the most common cancer amongst US women and the most common cause of death. So at age of 40, I always recommend a mammogram, and I always recommend after age of 20 to do breast exams on a self-breast exams. If I will be posting just for a knowledge base about how to do a self-breast exam and also how to do a self-testicular exam, if anyone is interested, because I just think it's a great chance to throw some in there. This is a lot of genetics. The area where I grew up in on Long Island was actually right next to an electric grid, and there's a high incidence of breast cancer. And I feel like that's plays a huge role in how breast cancer is developed, because that means mutations are occurring. But side note, so some of the risk factors is that there's a family history of breast cancer. Some people might have heard the gene BRCA1, BRCA2, that is the gene that's associated with breast cancer. If they have no or short periods of breastfeeding, that could sometimes put someone more at risk of breast cancer. If there's no pregnancies, or first pregnancy is late in life, and depends how late you want to call that, so they say it's a risk factor. And then getting your period really early, or stopping menses really late is considered a risk factor. And as said, BRCA1, BRCA2, we always try to look, if someone does test positive for BRCA1 and BRCA2, the current methodology is that they do a prophylactic, which means preventative mastectomy, as well as taking out ovaries to prevent the risk of cancer. And then as said, mammogram is really the best way to detect breast cancer. It's the easiest, most cost-effective way. Typically, women over age 40, they're screened every year. And then if I'm doing a clinical breast exam and I happen to notice that there is a mass, I will always order an ultrasound to confirm it. And then for really high risk women, we do diagnostic MRIs, which are much more detailed and much more specific. On a mammogram, yes, we are squishing the breast between two giant glass plates, because we need to see that surface as much as we can. What ends up happening is that we see something called calcifications. And these are, for some reason, associated with breast cancer. And we look for the calcifications, or sometimes like right here, you can see that this conglomerate of white right here is the malignancy or the cancer. So as far as the physiology goes, how does the female make eggs? It's called oogenesis. So remember, genesis to be born or to make. So oogenesis is the formation of the female, and it should not be game, the female gamete. It begins in the fetal period. So when biological females are in utero, they have something called oogonia, which are diploid, so two end stem cells that divide by mitosis to produce a primary oocyte that undergoes meiosis 1, and then a secondary oocyte that undergoes meiosis 2, and that produces an ova. But they occur at different stages of life, okay? So remember, the key differences here is that in the biological females, all their primary oocytes are produced only in their fetus aspect. In primary oocytes, meiosis is arrested in one of the phases. We'll learn more about that next week, about late prophase 1, and resumes only years later after some puberty hits. And then in secondary oocytes, the meiosis is arrested in metaphase 2 and is only completed after the first fertilization. So there's the full meiosis of an oocyte does not actually occur until it's fertilized. So that just kind of ensures that basically what it's ensuring is that, humans are not like other mammals where we can have litters. Yes, there could be multiple births, but the bodies are really designed for just one, maybe max, well, depending on optimum, but max 2 to 3 naturally. And most of the time when those multiples occur is because there has been some fertility work done. So at birth, females are presumed to have a lifetime supply of all the primary oocytes they'll ever have. So it's really important when that baby is in utero to practice good health to make sure their fertility future is happy. Okay, so as far as ovarian follicle, a follicle is what you're going to see inside that ovary itself. There's it's the functional unit of the ovary, and it's a single oocyte that's surrounded by 2 layers of cells. So we have pregranulosa cells, and granulosa cells. And those follicles then go through stages of development, which we'll go into in a moment. We have the primary follicle that surrounds the primary oocyte. So I'm just going to show you from here instead. So before birth, remember, females are born with all the eggs they'll ever have. So we're taking a look here. So this is happening in the fetus. So oogonium stem cell mitosis, meiosis is arrested, and then until about puberty starts, then it starts again, primary oocyte, then it's arrested. Primary oocytes become secondary oocytes, and then the secondary oocytes are then arrested again until they get fertilized. So I'm trying to show you a picture here that's a little bit easier to look at. So here's what we're looking at as far as layers of cells. Okay, so before birth, there's just this primordial follicle. The primordial follicle, once it's stimulated by puberty, ends up becoming a secondary follicle. And then that's before puberty. Then after puberty, FSH is stimulated to help this follicle mature so it could be released. So that's where we get these different layers of cells that occur. Okay, I'm not going to have you guys really respond for the layers of cells. I just want you to know about the follicle itself. And then during ovulation, what happens is that there's another hormone called LH that surges, and it causes ovulation to occur. And then this egg gets out into the fallopian tubes from the ovary, and the residual that is left over from this follicle becomes what's called a corpus luteum. It's bright golden yellow for a reason. It's making sex hormones. It's making progesterone. You need progesterone to be able to hold a pregnancy, to keep that lining nice and thick in the endometrium so it can implant. What happens in certain diseases like polycystic ovarian syndrome, it's not that there's actual cyst, is that these follicles just don't get developed, and you don't get corpus luteum, so you don't have that cyclical every month period. So women will have irregular periods, and they'll have, if you did an ultrasound of the ovary, it would be called a string of pearls that you would look on an ovary, because all these follicles, they have almost like a cystic appearance, but they're not, because they're just empty follicles that aren't releasing eggs, okay? Hopefully that was a little bit, that was not too confusing there. Sorry about that. And then follicles, they have 2 steps. So they only one gets selected per month to ovulate, and the rest go through apoptosis or atresia, which is a programmed cell death. And that's because we don't have babies in litters. Gosh, I'm 4'10". I really hope I don't have a litter for when I have more babies, if that happens. Okay, and ovulation, so we'll go into that in a moment, what happens there. But what happens is that FSH rises, and that promotes FSH is follicle stimulating, so we're stimulating to get more mature. That's causing more estrogen to surge. When the estrogen surge it comes up in a pulsatile manner, it'll cause LH surge. So when someone's testing on a urine stick to see if they're ovulating, they're testing the LH content in the body. Once that LH surge occurs, the egg is released. Then that the follicle starts becoming corpus luteum, and it secretes progesterone. And then depending if there's fertilization or not, then if there's not fertilization, what ends up happening is that corpus luteum degenerates into a corpus albuginum, because there was no feedback mechanism to let that know that there's a baby there. And the uterus will shed because there's a sudden drop of hormones. And sudden drop of hormones in certain females can cause irritability, anger, bloating. We'll go into that in a moment. That's what causes PMS or premenstrual syndrome. So as far as products of meiosis, so in the female body, it's a little bit different. So remember, we only get 1 actual egg instead of 4 sperm coming out of here. So let me just pop back here. So in oogenesis, primary oocytes are arrested in the fetus in prophase 1. And then what we have is that there's a dominant follicle that is produced, and it's just by chance. Dominant follicle will then resume meiosis 1 just before ovulation. Then after division of meiosis 1 is completed, you'll have 2 haploids, so just 1N cells that are different sizes. You'll have one that's a first polar body, which is basically just a fragment of the dominant follicle, and a secondary oocyte, which is a larger aspect, and it has the mother cell, which is almost all the mother cell that it came from, with the cytoplasm organelles. So the first polar body is just fragments, basically, and the secondary oocyte is what we need to occur. Then the secondary oocyte stops in metaphase 2, and and it will become ovulated as an ovum. Okay, so if sperm does not meet up with this oocyte, the oocyte just degenerates. Okay, if this sperm hits the egg, then the secondary oocyte, as I said, starts meiosis two. The ovum the ova will become ovum. Sorry, the secondary oocyte will become the ovum, and that will have enough cytoplasm in it so it can nourish a fertilized egg. It's basically like giving it juice to keep going. And it says here 6 to 7 days. It really does take about 4 to 5 days for it to go into the uterus, but 6 to 7 is a longer aspect. And then we have a second polar body that just basically degenerates and dies. So here's taking a look at what happens here. So we're here in that meiosis 2. That meiosis 2 forms up with the sperm, and then we get the ovum here. And then we also get the second polar body. So we're starting up here before ovulation. We have the first polar body in a secondary oocyte. Okay, ovulation occurs. We have a meiosis 2 of the polar body. It can happen. And then we also have the sperm, and then it starts doing it all over again. Okay. So as I said, that gametes always, in the end, we have haploid ovum. So in oogenesis, we have one viable haploid ovum or one haploid egg and 2 to 3 haploid polar bodies. In spermatogenesis, we have 4 viable sperm. And why does this happen? Because sperm can die really quickly on their way out or their route to the egg. And that's why they need as many chances as they can for procreation. Okay. And then when does oogenesis end is when menopause ends, which is when the body's, the ovaries basically like, I'm not secreting any more estrogen. And it stimulates FSH to rise. And typically when a female's FSH is at 32, we assume they're in full menopause, okay? So as I said, follicle development, I kind of went into it a little bit, but I'll go into it again because it's kind of confusing. And I actually just want to go to my, here we go. I'm going to go right here, sorry. So primary follicle becomes a primary follicle. The primary follicle then becomes the actual ova or the oocyte starts secreting the substance called the zona pellucida, which is like a very bouncy eggshell that, not a true shell, but a bouncy eggshell that encapsulates the ova. So we could see that here. So there's that bouncy eggshell right here, okay? From there, the primary follicle becomes a secondary follicle. And in the secondary follicle, we have these cells called granulosa cells and theca cells. So the theca cells themselves are what secrete, they secrete more estrogen in response to LH. Let's take a look there. And then the secondary follicle, it becomes an antral follicle, and this is basically what needs to happen before it comes out. And we're gonna go more into this again during next week. So basically the secondary follicle becomes a vesicular follicle that the oocyte then has, with the granulosa cells, makes even more fluid called the corona radiata. Corona radiata then sits on a stalk on each side of the follicle, and then it's ready to be ovulated, okay? And after the oocyte and corona radiata are ejected, it ruptures. You can actually see if we're doing fertility studies, you can do a ultrasound and you can see if someone has ovulated, because what you see is an oocyte and the corona radiata literally make up like a little hole, and we could see that little rupture occur sometimes in real life, and then it's left over to make the corpus luteum. So in a nutshell, what I want you to know, it will be, sorry, I'll just scratch it. I want you to know about that. And then the ovarian cycle is basically like the menstrual cycle, but the ovarian cycle is 28 days long, and there's 2 phases of it, and it coincides with the menstrual cycle, okay? So the first phase of the ovarian cycle is called the follicular phase, because that's the phase where we're having that follicle mature and grow. That's from days 1, and we always count day 1 of a menstrual cycle or ovarian cycle, the first day of bleeding. And that goes into day 14, and typically females ovulate on day 14. For the most part, that is same for every biological female, but what makes it different and why people have different, the next phase, the luteal phase, is what can change. There are some people who ovulate much earlier, but it's really the luteal phase that changes for the most part in the body. And the luteal phase, so once that ovulation has occurred around day 14 and the corpus luteum is starting to secrete progesterone, that's from days 14 to estimated 28. In real life, 24 to 32 days is where anywhere can be in the cycle, okay? So I'm gonna go to my, there is, hold on, there, oh, geez. So yes, I'm going through a lot of slides here because what I wanna show you is my graph here. I've already talked about a lot of this, how we're having an LH surge that triggers ovulation. So I'm trying to get to my graph here. Okay, stop it. Where's my graph? Okay, there we go. So right here at the beginning, so there's a lot of jumping. Right here, day 1 is bleed day. We're assuming this is day 8 of day 28, which means the end of the cycle. What's going on is that in puberty, that GnRH, just like in the males, is going to do a pulsatile surge, and it's called LH to surge, which will then really get the estrogen to start flowing. So at day 1, these levels are really low because we're at day 1. We shed the female has shed the menstrual, endometrial lining, and they're ready to start from scratch in hopes for an implantation. So we initially have this FSH that gets that builds up, builds up, builds up. It gets a surge. Not too much of a surge like an LH, but it increases. And that FSH has now stimulated the ovary to be secreting estrogen. That estrogen then will rise, rise, rise. And it'll cause, in response to this, LH will rise, rise, rise. LH will pulse up, do a huge spike, and it'll cause more estrogen to occur, which causes ovulation. And then that LH and FSH will dip down. So we're looking right here, if we're looking at how the follicle look like in the ovarian phases, we have the follicular phase here. This is day 14, ovulation, boom, we'll see that. Corpus luteum and degeneration. And to look at estrogen, so if we put that FSH and LH surge right here, this is where estrogen and progesterone would be. So this is the midway, this is ovulation, this little green to blue area, okay? So the beginning, estrogen rises, progesterone's pretty low. We have ovulation, so that corpus luteum has been formed. Estrogen starts, it takes a little dip, but then takes a little bit of a rise, but it's really progesterone that takes over. And then once that lining is ready to be shed, if there's no pregnancy, it will dip down. If it does a pregnancy, this will stay pretty even, and it will help the HCG, which is the human gonadotropin, human chorionic, HCG is the pregnancy hormone, and that will help it sustain a pregnancy. Now, sometimes what can happen in here, and you're like, well, Dr. Wood, you're a naturopathic doctor. Maybe you're thinking that, maybe you're not. I don't know. But what ends up happening here is that, see how this estrogen takes a rise and this progesterone takes a rise? Sometimes estrogen, for some reason, doesn't take a far enough dip. And we have what's called estrogen dominance in the last half of our cycle, of a female cycle. This estrogen will stay rise and can cause difficulties with PMS and whatnot. Because estrogen is really the main thing that causes the bloating and the irritability. Progesterone is more what I consider a mellowing thing. It just makes you chillax. And then if we're looking at the actual endothelium lining, what we're seeing here is, so day 1, we're having the FSH, and what's happening is in response to the FSH and the estrogen, it's causing the, around day 4 to 5, so the female menses last anywhere between 0 to 7 days. Can be longer, can be shorter, depends on the person. And fun fact that once a person starts their period, which is called menarche, it takes about 4 years for the female body to figure it out. And periods can sometimes not regulate until age 16 or 17. So what's happening here is we have that FSH stimulating, the estrogen rising, it's calling this proliferative. So you see how these spiral arteries are starting to get formed. We have our LH surge and our progesterone. The progesterone keeps that lining of the endometrium really nice and thick, causes those blood vessels to invaginate, more endometrial glands. And then if no pregnancy occurs, then it starts to shed because there's no progesterone keeping that lining thick. Now we're talking about birth control as far as Mirena or Skyla, which are types of intrauterine devices. It will keep this area artificially thick, confusing the body, think it's kind of pregnant to avoid implantation. And then if we put them all together, that was the slide I was trying to find. If we put them all together, we're seeing how everything matches up perfectly, okay? So what can cause irregular menses? And this is really important. When someone is either right before their period or on their period, for their dental exam can make them much more sensitive, can make them more ready to cry. Pain tolerance is a little bit lower. A lot of things can happen. And what happens is that sometimes menarche typically happens around age 10 to 13 or 12 to 13 ideal land, which is the first period. And extremely strenuous activity or stress can cause cessation of menstruation, known as amenorrhea. Sometimes in female athletes, because they have little body fat, they're little body fat. So body fat, adipose tissue secretes estrogen, which is a little bit helping there. But female athletes, because of little body fat, their leptin, because there's no leptin being there's no leptin being really produced. This can shut down the reproductive cycle. And in reverse, if a woman's body fat increases a big time, it can actually secrete more estrogen and cause other issues as well. So I say this a million and one times, that stress can influence cycles. Number one cause in stress can be the number one cause of unidentified infertility. That is my opinion. That is not fact. I noticed that when women are stressing out about trying to get pregnant, you send them on a vacation, they get to relax, boom, they're pregnant because they weren't stressed. They went to Maui, they had a Mai Tai, those type of things. And what does estrogen do to the body? So when it's in high enough amounts, it's going to promote that oogenesis and the follicular growth in the ovary. It does have a little bit of an anabolic effect on the female reproductive tract. It does support rapid short-lived growth spurts in the puberty aspect. And then it causes the secondary breast characteristics. So whether it's biological female or transition male to female, if we put estrogen in the body, it's going to grow breasts. It's going to increase adipose tissue around the hips, and it's going to cause whitening and lightening of the pelvis. Okay, and also estrogen has some metabolic effects. So recent studies show it helps calcium uptake, and also it can also help maintain a lower blood cholesterol and high HDL levels. So sometimes in menopause, we do something called hormone replacement therapy for two reasons. One, to help minimize the symptoms, which are quite brutal, of menopause for some women. It's good for their cardiovascular health, and it's also good for their bone health, because estrogen is needed for good bone maintenance. And then progesterone will work with estrogen to regulate that uterine cycle, like I talked about. Okay. Once there is a placenta in place, it will make its own progesterone, which is why the progesterone stays for a while. Okay. So the progesterone that in corpus luteum stays for a while, and the placenta has enough progesterone to make itself, and that inhibits uterine motility, which means it won't cause spasms like cramps, and helps prepare the breast for lactation as well. There are 3 different types of estrogen that the female body makes naturally. One is estriol, and that's the one that comes out during pregnancy. There's estrone, and once someone goes through menopause, it's really estrone that takes over as the main estrogen. And the one that we mostly know about and the most we care about is estradiol. And estradiol is what gives that secondary sex characteristics the most. And when estradiol dips during menopause, that's what females feel the most. Okay. Now, what is happening when estradiol production stops? Mood swings, weight gain in the middle, decreased libido. Sometimes there's thinning of the vaginal mucosa or dryness of the vaginal mucosa, joint pain. As I said, there's sarcopenia, so there's muscle pains that can occur. The skin and hair, sometimes you'll have increased wrinkling, reduced elasticity of the skin, and hair loss. And really that mood change, the mood and sleep. So, and the other big part is vasomotor. So vasomotor means hot flashes, night sweats. And as I said, HRT is our hormone replacement therapy, is a treatment of choice for some people. There are certain people there's certain people who should not do it, and you have to talk to your doctor about that. Okay, they come in different flavors, different types. You could take a look at how to do that. Allergy pill has not happened yet. Okay. So as I was saying about menopause, it's not commonly discussed, but there is andropause that occurs in the male. It's just not, some school of thought doesn't believe it happens. I do. I think it happens. So andropause is basically the lowering of testosterone making ability. You're still going to have testosterone, just not going to be as much. And what's going to happen is that sometimes when men get older, they'll have some cognition declines and depression, thinning or hair loss. They might have increase in body fat. They might have some testicular atrophy or sexual desire, sexual dysfunction can occur. And they might also see some gynecomastia because what's happening is that estrogen in their body is able to rise and cause some breast tissue appearance. Okay, here's a little comparison. And then female sexual response, just like in males, there's no really point and shoot because there's, well, we won't get into that. Female sexual response is same thing, psychological and initiated. The only thing that is different in the female is that there is no refractory period for some, okay? And then female libido is really stimulated by DHEA, which is an androgen, which is why sometimes we supplement testosterone for low libido, which is a very low dose topical. So basically, person prescribes a testosterone cream and asks them to put it on the outside of their vulva, and that causes that libido and that sexual sensation to be there. And then sexually transmitted infections. I don't know when you're going to learn about it or how you're going to learn about it, so I always put it in here. So sexually transmitted infections is also known as venereal diseases. No one ever uses that term anymore. The only way to really prevent any sexual transmitted infection is just not to have sexual relations. But in a real world, latex condoms is the best way to prevent its spread, okay? The only ones that I'm going to highlight here are the things that you're going to see in the mouth. So we're not going into too much depth here because, yes, sexual transmitted infections can occur in the mouth. I cannot tell you how many times, this is going to sound horrible, how many times I've seen chlamydia or gonorrhea in the oropharyngeal zone, okay? So chlamydia, most common bacterial STI in the United States, is caused by chlamydia trachomatis. So it's mostly responsible for what's called pelvic inflammatory diseases. So as I said, it normally occurs, it affects the cervix, but it can occur in the throat. This is a lovely look at someone's throat when they have a chlamydial infection. See all this white gunk here? That is not supposed to be there. So sore throat and discharge of the throat are common when you see it in the pharynx. But if you're in clinic and you happen to hear someone say that they're having vaginal discharge, abdominal rectal or testicular pain, painful intercourse, irregular menses, you might want to say you want to talk to your doctor, okay? Another STI that's pretty common is gonorrhea. Most infections are asymptomatic, which is why pelvic inflammatory disease can be so common. In males, females don't normally have a ton of symptoms, but males are normally the ones who do have the symptoms. So this includes in males for the penis, there's urethritis, which is inflammation of the urethra, very painful urination. Sometimes we see discharge of pus from the penis called as the penile drip. And then if we don't treat this, it can cause inflammation of that entire duct system as occur. I said it can occur in the oropharynx, but never cause symptoms, which means it could always be a pathway for infection. We have syphilis, which doesn't typically occur in the oropharynx, but I like to talk about it anyway. So syphilis is by a treponemium, and it is pretty bad. Bacteria invades the mucosa, broken skin. Infection is normally asymptomatic until a painless chancre, which is a sore that has no pain, appears at the site of infection and disappears within a few weeks. Some people are like, ooh, I'm treated. No. When it disappears, it means it goes into the rest of the body and starts affecting the body. Do you want to know what the most common cause of dementia lately in nursing homes is? Syphilis. Because tertiary syphilis affects the brain. And guess what the older folks are doing in that nursing home? Getting jiggy with it, okay? And then we have HPV. So HPV is most commonly as genital anal warts, but we can see them in the pharynx. There's a #1 common cause of throat cancer. HPV, if it's strain 1618, it is linked to cancer-causing issues. That's why we have a vaccine. So that's it for the female reproductive system. I know I skipped through a lot of slides because I actually did a lot more talking rather than looking at the slides. Feel free to ask me any questions, as this is definitely one of my areas of clinical expertise. But don't ask me any medical, like how do I treat this? You can ask me about physiological questions. I will see you guys tomorrow or 3 days from now, or I'm not sure when I recorded this.